just before we move on to the next speaker, I just want to do 2 little bits of advertising. It's taken us over 2 years to get our website up and running again. And we are absolutely delighted to announce that the SAPA website has been rejuvenated. It's got a fantastic, fresh new look. The SAPA exec have been very busy doing this, and the new website address is pediatrics.org.za. And I'm really going to encourage you guys to have a look at it and to become members. And while I'm on the advertising streak, we've also got our SAPA as a virtual congress, 13th to 15th of August 2021, Striving for Thriving Kids. It's really a congress with an amazing difference. So not just virtual, but some really interesting topics and workshops. So that's also on our website, and I'm going to ask you to log in and to register for that. It should be a lot of fun. So thank you for allowing me to do a bit of advertising, and I'm going to hand back over to Mati to introduce our next eminent speaker. Thank you, Alan.
Okay, great. Thank you so much for that, Mignon. So we are back with our second speaker, so Alan Horn. I don't think you need that much of an introduction. He is one of our neonatologists at Groote Hospital, and he is also a fantastic ultrasonographer. So I've learned some point of care, even cardiac ultrasounds from him. And they've really taught us how to do basic cranial ultrasounds. And that's where this whole idea started of doing a presentation on it, because I think it really helps you if you can do basic anatomy scans on small babies. And it helps you with prognoses and just to know what's going on with your baby. So thank you so much for joining today, Alan. We really appreciate it, and we're looking forward to your talk. Great, thank you.
Thanks, Marchi. Hello, everyone, and thanks for having me. Can you see my screen all right?
Yes, we can see it very well. Thank you.
Great. I just need to shift some things around on it so that I can see it. Right, so to begin, the why and the who. Well, why we do scans is partly because we can, because it's one of the few chances we get to look inside a baby's brain. It's going to give us a diagnosis to guide management, and the scans hopefully going to give us a prognosis. And who we do it on? Well, if there is a risk or a suspicion of brain injury or abnormality, we will do it. We'll screen all extremely low birth weight or babies under 32 weeks. If there's a history suggesting hypoxia or sepsis or cardiorespiratory instability, or if there's suggestive antenatal scans or neurological or systemic signs, anything really that could affect the perfusion or development of the brain. So ideally, the recommendations, most global consensus recommendations will suggest doing the scan on day 1 and day 3, and this is referring to your very prim babies. Other babies, it's going to depend on when they present, etc. But from a screening perspective, the first few days of life, particularly around day 7, and then weekly until discharge, or 40 weeks, whichever occurs first. And the additional indications, as I mentioned before, on the right-hand side there. In practice, if one has a baby on CPAP and interfering with the baby is going to mean extra handling, then there's not really a great rush. The scan isn't going to change the management, and one would generally delay these scans for the first couple of days until the baby is more stable, but ideally by day 3. Then a repeat around about a week later, because a lot can change in the first week, and approximately every 4 weeks thereafter, and a discharge of 36 weeks. The more frequently the scan is done, the more frequently we'll gain information, but that needs to be weighed up against more frequent handling and infection risks. So an individualized approach relative to resources and the stability of the baby is needed. So this talk will then look at anatomy and brain maturation. We'll have a brief look at transducer choice, orientation and optimization of the image. We'll look at the standard 2D imaging windows, look at Doppler, and then we'll look at pictures showing hemorrhage, Leukomalacia, a slide on stroke, HIE, and some germinolytic pseudocysts, simply because these are the common things that come up and get confused with each other. There's obviously a lot more that one could say. So the starting point is anatomy. One can't do the scan without some concept of anatomy, and one needs a three-dimensional thought process. So these are just some images that show how the ventricles are in the middle of the brain, that you've got your two lateral ventricles, that they are angled towards each other in the front, splayed out towards the back, and so your probe is going to have to take that into consideration, your transducer, that the third ventricle is connected, and then there's the cerebral aqueduct going into the fourth ventricle. The image on the right really just shows the 3D orientation of the brain, and I'll show a couple more images. The image at the bottom is obviously a post-mortem specimen showing, again, trying to demonstrate where the structures sit in relation to each other. Now, I want to, and I don't have shares in this company. This is from Royal Prince Alfred Hospital, and Nick Evans has produced a CD which is available in our Krutzgear computer. It costs 25 Australian dollars. It is the best educational tool I've come across for head scans. I will be using some images from it with Nick's permission. And you can see in these images, when one interacts with the program, that one can basically build a brain bit by bit and get a complete grasp for its 3D nature, and in so doing become familiar with the anatomy and hence know what one is looking at. The other aspect to consider throughout, well, when one starts looking at the brain, is to know what is the gestation of the brain. And in essence, the more folded, the more sulky and gyry there are on the brain, the more mature the baby is. But certainly the olfactory sulcus, which I'll demonstrate a little bit later, tells you that the baby is more than 24 weeks old. When we see the temporal sulcus, and you can see that on the image above, then we know we're at 28 weeks. And when we start getting branching of the sulci, then we know that we have gone beyond 32 weeks. So some idea of the maturity of the brain is needed. Then there's the windows. Now, traditionally, I don't know if you can see my pointer. Can you see this pointer, this arrow that I'm moving around?
Yes, we can.
Oh, good. Okay. So the anterior fontanelle is where all the emphasis is, but actually we should all be using the posterior fontanelle views more, and the mastoid views and the temporal window. And I would encourage people to start practicing and utilizing those views, and I will be talking a little bit further about them. But to begin with the one that hopefully we are at least more familiar with, the anterior fontanelle view. This view, you will all know, of course, that there are coronal cuts shown here, typically 6. So your transducer is in a horizontal alignment, and it moves across backwards and forwards in that way. The sagittal, the probe is turned, and so we get a longitudinal, as it were, cut through the brain, as shown here. And this is looking down at the top of the brain, showing how the images would look. Now, before we go into the details of those, a brief word about transducer choice and orientation. Micro curved array transducers are the recommended type, but you can use a phased array, which has got a flattened head if the fontanelle is too small for the curved transducer to be useful, or even if you don't have a curved transducer. It's just about resolution. Most transducers are multi-frequency, but when you set up, you will still need to choose. Now, of course, when you have a machine, there should also be an application specialist who should help you set it up. But I think it does help to have some insight into what you're setting up, particularly if you need to change the image. So generally a higher frequency is going to give a better resolution, and a lower, minus the E frequency, is going to give you better penetration. In other words, if you use too high a frequency, you won't be able to see deep. you'll see excellent higher up, but you won't know what's going on lower down. Now, most imaging can be done at all depths appropriately if you set a middle zone of 7.5 to 8 megahertz. For very small babies, you can probably see the entire brain, even at 10 or 11. And we sometimes will selectively use a very high definition probe when we want to look very superficially. For bigger babies with thick hair, then one may need to use a lower hertz or indeed shave the scalp if need be. Now, the orientation, Barry mentioned the notch of the transducer, so this should generally be to the right of the head or to the front if you're doing a sagittal cut, and the marker on the screen will match where the notch is. So you'll know if you have got the notch the wrong way around, if what you're seeing is not appearing on that part of the screen. Image optimization then, and I'll just go through this very briefly. All of these options will be on your machine, and again, they should be set up as a preset, but having some insight into them does help you when you're looking at the images. The depth option should be adjusted so that the entire brain that you're looking at fills the screen. You don't want your tiny little brain at the top of the screen. The gain, which is the brightness, should be adjusted so that the skull bones aren't very fat and overly thick. They should be true to life. The focal point is the depth at which the image is focused, funnily enough. And that should not be set too high. If it is, then the image will deteriorate below it. So rather set the focal point far down rather than too high up, or add additional focal points. The dynamic range or compression, it determines how many shades of gray you have. The time gain compensation adjusts the image at various depths, and this can be done automatically on most machines. Tissue harmonics detects and removes artifacts, and that should generally be on. With all of these, there can be a trial and error, and you can see if it improves the image or not. But in general, I would expect it to improve the image. Spectral reduction similarly removes artifacts. Compound imaging sends multiple beams from different angles to improve the resolution of these artifacts. Gray maps again give you a different brightness of each shade of gray, so it can make the images easier or more accurate. The line density, the more line density, the higher your line density, the higher your resolution, and the lower your frame rate, and the frame rate persistence setting averages out frames to smooth the image. Then the reject setting is to reject artifact, and edge enhance is to sharpen the image. So as dull as it may seem to go through all those are enormous tools to actually provide an image that is useful to you. And here we see the effect of increasing the gain from just right to too much, from decreasing the dynamic resistance from just right to too little, where we get fallout around the edges, and from having an incorrect time gain to a correct one. And the other thing is the sector width, if it's too wide and you're getting fallout, or if it's too narrow and you aren't seeing what you need to see. Now then, to actually look at the planes, which is what the meat of the talk is then about, these are the 6 cuts that we'll look at, and they are standard views. Now, obviously, if you have pathology in other areas, then you will be looking at those areas, but these are the standard views. So the frontal view, and here you see the orbital at least the olfactory sulcus, showing that this baby is at least more than 24 weeks. You'll also see the interhemispheric fissure. Then we'll get on to the next view shown here by number 2, where you're cutting through the frontal horns. You can get the cavum, septum pellucidum, again, the interhemispheric fissure, and the frontal lobes and the temporal lobes. And this is the insula that we're seeing, but ultimately that will become the sylvian fissure. On the next view, we see those same structures, but a little bit further back. And here we should also be cutting through the foramen of Monroe. This is the view at which the ventricular index, which I'll show later, is measured as well. The next view further back, we're now on the lateral bodies of the ventricles. We can see the hippocampal gyrus curving around. We can see the cerebellum coming into clear view with the hemispheres and the vermis. And we can see a nice closed off sylvian fissure, which in a preterm baby would be much more widely open. Then the next view is going through the trigone, which is basically the triangular part of the lateral ventricles, showing the choroid plexus, and one can also see a bit of the corpus callosum there. Also, you can see the corpus callosum on these other views earlier on as well by this double line over here. Then when we go right back to the sixth cut, here we're cutting through the parietal and the occipital views. We can see the parieto-occipital sulcus, and we can also see the central sulcus coming in over there. Right, then on the sagittal plane, we take 3 cuts either side, and these are numbered differently in different texts. Here they're numbered 1 to 5 going right to left. But if we start with number 3 in the middle, here you can see your cingulate gyrus, your corpus callosum, your third ventricle, your aqueduct, your cerebellum, your pons, and your fourth ventricle. A classical midline cut looking at the anatomy. Then when we get to the first cut, or number 2 it would be, if we look on this side, here you should be able to see the ventricle outlined here like a C. So the head of caudate is being shown over here, and down here we've got the basal ganglia, the thalamus, the ventricle containing the choroid plexus, pericampal gyrus, and an important marker is the caudothalamic groove, separating the caudate from the basal ganglia. And at the outside, we've got the cerebellum and the occipital lobe. Again, I mentioned earlier how the insula is open in preterm babies. And here you can see how it is open in a preterm baby and completely closed up by the operculum in an older baby. So when we go further out, this is what we see, the closed insula. This is the superior temporal sulcus that I mentioned before, and the central sulcus. Right, when we go, now we're looking at the other views that I said we should start looking at, the posterior fontanelle views. I'm not going to read out all the anatomy in detail, but very broadly speaking, it's very similar to the anterior fontanelle views, but just a little bit further back. And the real beauty of this view, you'll see similar views through the cerebral hemispheres and the choroid plexus. But when we get further down into the sagittal cuts, where we've angled the probe up and down, we can actually get a much clearer view of the occipital horn of the lateral ventricles, and that helps us distinguish bleeding from choroid plexus. Similarly, in these other views here, it gives a slightly different view and a different angle of white matter as well. The mastoid fontanelle is the other view to look at, and this view is really the best view to look at the cerebellum, which is often obscured or compromised by the tentorium. So here, the position is just behind the ear, and you'll need to move the probe around to find your best views, but you should see with it aligned horizontally these pictures here showing the cerebellum and the pons, the fourth ventricle and the megacisterna magna, and this is another view slightly further back. The middle and inferior views, and then if we look the superior and inferior coronal scan, so with the turn the other way, we will see a slightly different view of the cerebellum, showing a better view of the cisterna magna and even the folds of the cerebellum itself. The temporal window, if you remember from that first picture I showed you, is just in front of the ear. And this really gives you a view that is the similar kind of cut to what one will see with a CT scan. So a transverse cut across the brain. And here you can see the basal cisterns, And you can see an outline of the circle of Willis, which is now highlighted here when one puts Doppler on, and is ideal to examine the integrity of those vessels and to study them using Doppler. And there one can see the cerebral peduncles. The next concept one needs is to have an idea of the venous drainage, to know that there are medullary veins, that there is a terminal vein, and that there is a straight sinus that drains down, and connecting that is the vein of Galen. We'll come back to these later on. And then to have a concept of the arterial circulation and where it drains. And again, this is a picture from Nick Evans' CD, where one can take the brain apart and put it back together again and see exactly where the vessels are and how they run. And but we're particularly interested in the pericallosal branch of the anterior cerebral artery, the middle cerebral artery, posterior communicating arteries, because they serve critical areas of the brain. And again, this is down here, just a view showing again the circle of Willis and how the middle cerebral artery comes off. These we're particularly interested in when we're suspecting a stroke. And the way we will interrogate them is to put Doppler on. And this is now on coronal cuts. So one can see circle of Willis. And again, red is towards the transducer, blue is away. The pericallosal branch which we will use to calculate the resistance index. And then this image on the side here is looking at the sagittal sinus and the venous drainage. So periventricular hemorrhage, as you will all remember, this emanates from the germinal matrix, which is a very vascular supplied bunch of neuronal cells. In fetal life, it covers the lining of the ventricles and it regresses, and by 34 weeks, it's almost completely regressed. Now, the pathology of bleeds is that there is initially a hemorrhage in this area, which may be all that happens, but when that happens, venous congestion happens, and it is that venous congestion which subsequently results in infarction in the parenchyma. It is not that the blood bursts through into the parenchyma, which is why it is possible to have parenchymal injury with a relatively small bleed. So the causes relate to deficient development, fluctuating blood flow, or thrombocytopenia and coagulopathy. It can be antenatal, and if we do see antenatal bleeds, in other words, we see it very early after the baby is admitted, if it's present already when the baby is admitted, then we're particularly interested in those coagulopathy problems. And generally, most bleeds will have occurred by 72 hours. They're graded, as you know, that if 1 is limited to the germinal matrix, 2 is into the ventricle, 3 is occupying more than 50% of the ventricle, which may be distended and usually is. Grade 4 is when there is a periventricular venous infarction, hemorrhagic venous infarction occurring because of the process that I mentioned earlier. And there is an IVH, which may be of any size. You do not need a grade 3 size IVH in order to have a grade 4 hemorrhage. Any size that is causing that congestion can be implicated. So the pictures of the grades, you'll see here a grade 1, it is not extending into the ventricle, a grade 2, a little bit extending into the ventricle, and here's the post-mortem specimen. And it's often useful to use Doppler as well, because what you'll know is that clot does not have vascular Doppler signal, whereas the blood supply will. And what we can see, you'll remember the image of the terminal vein. What's happened here, there's a big bleed. The terminal vein, which here you see in blue, is completely obliterated here, demonstrating the pathophysiology. Then the grade 3s, so here we've got more than 50%. All right, this is an easy one, it's the whole ventricle. But here we've got more than 50% filled. You can see not striking dilatation, but the key is that it's more than 50% full. And you can see this multi-toned dense area showing that it's not just choroid, it's also blood. Whereas here a few days later, it's expanded. It's now very obviously more than 50%. And you can see the inferior horns also full of blood down there as well. And that's the lateral view. Then the grade 4. So here we've got an example of a grade 4 where there's a small bleed, but there's definitely parenchymal involvement on both views. Here, there's a bigger bleed showing the parenchymal involvement up there in the temporal area. These are some older scans with poor resolution. And then the post-mortem specimen to match it. And then the ventricular index I mentioned. So as we said in the view where you've got the foramen of Monroe, and this is a post-mortem specimen just to show it more clearly, we want to measure it at that value and we want the widest measurement. Now we have generally Levine's charts are used where the centiles are developed. And if it's more than the 97th, we say this is abnormal. And if it goes more than 4 millimeters above that, we say this is now needs to be considered for surgical intervention. However, those Levine's study, as you'll know, was done more than 50 years ago. And this has recently been updated by 2 authors, the most recent of which is Boyle et al. And you can see that their values are similar, but that they're about 1 centimeter higher. So I would encourage people to use the newer charts going forwards. Then periventricular leukomalacia. So here, I know the talk was meant to be about bleeds, but I think we do need to distinguish them from PVL. PVL happens because of a watershed area between the short, the long, and the basal penetrators. And it is also extremely modulated by inflammation, inflammatory and ischemic modulators. Grade 1 is when you get periventricular densities more than 7 days. Grade 2 is when they evolve into small cysts which are localized. Grade 3 is when they're more extensive, and grade 4 is when it actually extends subcortically. So just to show you the images, here we have grade 1. There are no cysts. It is just a very dense area that is a similar density to the choroid plexus. And here is a smaller area, but it is well defined, and it is, in particular, it is not homogeneous. So it is patchy by its nature. Grade 2, we have cysts developing that are localized. And grade 3, we have more extensive cysts. And grade 4, they're extending right up into the subcortical area. Just a note on cystic PVL, cysts can get squished by the brain if it is edematous and swollen. And often we will see cysts changing in appearance from week to week. Here we have an example on day 4, no cysts. At 6 weeks, we saw a cyst. There may have been more cysts. We see a ventricle that is slightly dilated, probably ex vacuo dilatation. A few weeks later, we don't see the cysts at all, but we do see this residual slightly dilated ventricle, suggesting that there may be some brain atrophy. There is also, because there's an inflammatory process going on, cysts that occur because of events that have occurred shortly before the time of delivery may not manifest, obviously, until several weeks later. So here we see a brain that looked normal day 8, but at day 28, there was clear PVL. One of the big challenges is to know, is the increased density of the white matter abnormal, or is it a physiological normal? And the issue here is the optic radiations, and indeed other radiations, that when the long tract fibers are caught at different angles, they can appear dense, particularly the optic radiation. So luckily there's anisotropia, which we see in the due to the axonal density with water. And so if one sees a more dense picture in the sagittal view and a normal appearance in the coronal view, that suggests that what one is seeing is simply the optic radiation. And so here, the other thing, it may be quite a dense line. So here in the frontal area, these 2 dense lines are the anterior limbs of the internal capsule. And these lines here further back are the optic radiations. They are not pathology. And here you see a normal view on the sagittal image. Whereas here, this is pathological, patchy, increased density, which is still appearance, which is still seen further down. A quick look at stroke. When we look at stroke, now this is in a term baby who had low Apgars and had encephalopathy. We're looking for this diffuse increased area of whiteness. This is on the far sagittal cut. This is on the coronal cut. And here you can see them on the outside here, this diffuse area of whiteness on these cuts here. And this is involving the thalamus. This is all the same infant, and it is all arising from the right middle cerebral artery. And what this image down here is showing is how the Doppler, doesn't show it very well, but how it tails off, confirming the pathology. The images we see in HIE, what we look for is at the basal ganglia. Here on day 1, not a lot to show, but it becomes very clear on day 5, where we see this 4 columns, more striking in this baby here, where we see a swelling and ischemia of the basal ganglia. Not always, but this is what we look for, particularly in acute severe injury. Here it's affecting the thalamus and the head of caudate. The other thing we look for is white matter density and gray-white matter differentiating from normal here. So the gray matter immediately below the sulcus, the white matter should be slightly whiter in the middle, but here you can see it's distinctly increased, more so here, more so here, and more so here. We can also look with a high frequency probe, and we can see subtle changes in more localized areas. Here is an example where the density is increased, but the gray-white matter differentiation, in other words, the difference between the white and the gray areas, is not so distinct, it's blurred. So whether it's decreased or increased, both are ominous signs. And just to compare, this is a baby who didn't have HIE, had leukodystrophy, but that is the most extreme type of gray-white matter differentiation and increased white matter intensity. And then finally, one of the things one often sees and often gets asked about are cysts, again, in a baby who was often previously well, not always, but often. And germinolytic cysts are what we're referring to, where we see little cysts at the angle of the ventricles, or it may appear to be a string of beads. We may see it in the frontal area or parafrontal area. We may see it in the caudothalamic groove, such as here. We may see it spanning the middle, and they may be multiloculated. And you can see from the text underneath that there are various causes, and so one needs to investigate according to the clinical signs. If the baby has had a stormy course, has had any reason to have hemorrhages or low blood pressures, or swings in blood pressure, the cyst may be a resolving bleed. With or without that, we would need in these situations to exclude congenital infections such as CMV. And just remember, if we have if the history fits with a metabolic picture, that these cysts can also be a sign of inborn errors of metabolism. So those are the highlights of cerebral ultrasound. A very quick walkthrough. Again, I want to recommend you again to the interactive CD, which you can buy it as a download instantly online, of course, now. You can also get a CD if you want. And the other reference that I would highly, highly recommend is this 3rd edition. It is substantially improved and more informative than the previous editions of neonatal ultrasonography. Oops. No, I've done that.
Thank you so much for that, Alan. Yes, I don't know if there's any questions at this stage. I didn't see anything in the chat, so that was really lovely overview and a practical introduction, because there's so much to talk about, but it really gives us a good idea of where to start with cranial ultrasound. So please post your questions in the chat, and if you don't have anything now, we'll get to it later.